let's give a good welcome to Dr. Goodman.
Thank you, David, for that very kind introduction. I don't know if any of you ever have the opportunity to speak to groups, but the way these things normally work is they're lined up in a long time in advance. And when you speak, people always want to know, well, what is the topic? And they kind of want something engaging, a little unusual and different. And so I tend to give some thought to my topics. But here's the problem. A week away from the event, I'm looking at the date, I'm looking at the topic. When you get to be my age, you begin to wonder, what was I thinking about? That was the topic. So Jennifer called up and she said, well, will you give us some bullet points? I said, well, yes, I'll give you some bullet points. And I think she sent them out. Where are you, Jennifer? Okay, all right. Did you send them out?
Yes, sir.
Well, I was looking at them this morning, and again, when you get to be my age, even though that was only a week away, you begin to wonder, what was I thinking about there? All right, here's what I want to do. I want to begin with politics. I want to talk about why politicians that want to put you out of business are more successful than those that don't. And I want to talk about what lessons we can learn from that to have better success in politics. I want to talk about what Donald Trump got right, what the Democrats with their $3.5 trillion bill right now in Congress are getting wrong. And then I want to give you lots of opportunity to ask questions because you know more about what you're interested in than I do. And we have to wrap all that up by 1 o'clock. And so the question is, can I really do all of that? And how the hell do I know? Okay. All right, on the political side, I don't care whether you're Republican or Democrat, but you're going to find this interesting. Last year, the RNCC, which I think is the Republican National Campaign Committee or something like that, told all the Republican candidates running for the House of Representatives to not even talk about health care. They said, if it comes up, change the subject immediately. That was the message of the Republican Party to all the candidates running for national office last year. Now, while they were telling the candidates, while they were giving this advice, if you take the average premium and the average deductible last year and add them together, a family of four that wasn't getting any subsidy at all had to spend $25,000 before they got any benefit at all in the Obamacare exchange. That's like telling the family you have to go do the equivalent of buying a Volkswagen Jetta. You have to do that every year before you get benefits from your plan. The networks in the Obamacare exchanges have gotten narrower and narrower. Last time I looked, you can't buy individual insurance in Dallas right now that will get you in UT Southwestern. If things have improved, maybe you can tell me, but last time I looked, it was often, even the Blue Cross plan doesn't let you go over there, and if you're out of that network, they play zero. In the whole state of Texas, Obamacare insurance will not get you into MD Anderson down in Houston. And this is going on all over the country. This isn't unique to Texas. The most successful insurance company in all of Obamacare is a company called Centene. You ever heard of Centene?
Yep.
Centene started life as a Medicaid contractor. It now holds 1/5 of all the Obamacare policies in the whole country. And what is it offering? It's offering what looks like Medicaid with a high deductible. So if you don't want to take Medicaid managed care in your doctor, you're not in a network. You don't want to take Medicaid managed care in your hospital, you're not in their network. So we've had what I call a race to the bottom, and unfortunately, me and the people I work with, we are the only people talking about the problems of these narrow networks. And there's total asymmetry in terms of fairness in the market. People have a 6-week period to choose a plan. Suppose you had a sick child, chronic illness, you need real specialized care, so you go through all the networks, you pick the plan that's right for your child, you join. A week later, that plan can change its network, and that doctor in that facility is no longer there. That's allowed under Obamacare. You're stuck with the plan for a year. They gave you the network you wanted for a week. And then, from an economist's point of view and a taxpayer point of view, I find the following sort of remarkable. The main reason for Obamacare was to insure the uninsured. And even now, the media grades Obamacare based on how many people have obtained insurance under the legislation. But in the individual market, if we go back to before there was Obamacare, now remember we were in a great recession, and we compare that to the number of people with individual insurance today, and you would have thought if we didn't do anything, there should have been some increase, or a lot of increase. But the difference is only 2 million people in the individual market coming up to 2019, right before we got into the pandemic. 2 million people were spending $50–60 billion a year. For the newly insured, we could have bought each one of those Volkswagen Jetta, and not just once. We do that every year. That's the kind of money we're spending with such a small return. And even the 2 million is an exaggeration, because while the individual market has increased by 2 million, the group market has decreased by that or more. So I really haven't increased the number of people with private insurance at all. We just shifted, a few people from the group market to the individual market, which is another way of saying we're spending $50 billion a year and getting almost nothing in return. Worse insurance than before there was Obamacare, even for people with pre-existing conditions. So way back before there was Obamacare in Texas, I think all of you know this, you went to the individual market and you were denied coverage, which only happened about 1% of the time. But suppose it happened to you, what would you do? You would go to the Texas risk pool, and that was more expensive, but the plan you got was like a Blue Cross plan. You could go to any hospital in DFW, and I think there were 50 of them. You see almost any doctor. That was much better insurance than a person with chronic illness gets in the market today. Okay, so why, given the disaster that we call Obamacare, do we find that voters trust Democrats more than Republicans on the healthcare issue? And I've been thinking about that a lot, and over the last 9 months, consulting with Marie Fishbaugh, who's the Vice President of Domestic Policy at the Heritage Foundation, and we've come up with some ideas. And the most important is that Democrats are better at talking about health care than Republicans. And how are they better? They follow 5 rules that Republicans tend to ignore. And rule number 1 is you talk about benefits, not how you're going to get the benefit. So when Bernie Sanders talks about Medicare for all, what do you hear? You're going to get a pretty good health care plan. You're not going to have to pay very much for it. You never catch Bernie Sanders talking about how we're going to move 160 million people out of private insurance over to Medicare. If he got caught doing that, he'd turn off his whole audience. He talks about benefits, not about how they're going to get the benefits. So what do Republicans do? Well, over in the House, I think they voted to repeal Obamacare 70 times. And what did that mean? Well, they never told us, because I'm going to get this in a minute. They never really told us what the real problems of Obamacare were. In other words, what I just told you a minute ago, the 3 big problems, Republicans never talk about those 3 big problems. So we're going to repeal Obamacare, and you're left to wonder what that means for you. And then there finally was a Republican bill that almost passed. And I bet you a lot of you don't even remember what was in it, because the messaging was so bad. But I'm going to tell you they were going to block grant federal funds to the states. And if you're a normal voter, you don't have any idea what that means. And you certainly don't know how it's going to benefit you, whether it's being good or bad. Republicans violate the rule, Democrats stick to it. And then Democrats talk about people problems, and Republicans talk about complicated systems. So when Democrats talk about health, it's pre-existing conditions, high drug prices. Those are people problems. What do Republicans talk about? Well, we're talking about selling insurance across state lines, association health plans, short-term insurance, certificate of need. How many voters know what any of that means? Not very many. And then rule number 3 is you need to focus on the people who are most likely to vote. And here's where Democrats made a big mistake. Back when Obamacare was making its way through Congress, it was sold as a plan to insure the uninsured. And that's what everybody thought it was mainly going to do. But then it was Chuck Schumer who was the first prominent Democrat to observe publicly, the uninsured don't vote. Of the people who do vote, 95, this is before Obamacare, 95% of them already had health insurance. So what the Democrats ended up doing is spending billions and billions of dollars on people who not only were not going to vote for them, they weren't going to vote for anybody. Political mistake that they don't typically make, and more about that in a moment. So there's an opportunity here, though, for Republicans that they didn't take advantage of. What's the group that votes the most? What's the group that has the highest percentage of folks going to vote? Seniors, right? Okay. So what have Republicans done for seniors? Well, it turns out, you agree?
Oh, yeah. I'm at a bad table.
All right.
It looks good.
We have in our healthcare system 2 exchanges, and on paper they look really, really similar. You get a 6-week period, you choose a plan. Private insurers are competing. There's a government subsidy. There's no discrimination based on pre-existing conditions. On paper, they look a lot alike. One of them works really, really well. The other has been a disaster. The one that works really, really well is called Medicare Advantage, created by Republicans. 40% of seniors are there. The CDO says by the end of the decade, we'll have half the seniors there. But I think because of some changes the Trump administration made, it's going to be even a lot higher than that. Anyway, very, very popular. Over here on the Obamacare side, I'm going to tell you more about why it gets so bad. So why aren't Republicans out there running on a plan they created for seniors, the seniors really like? I never hear them mention it at all. And then, rule number 4 is you need to have an idea in health politics that easily differentiates you from your opponent. And you might think that is so simple, how could even an idiot fail to do that, right? But in fact, Republicans fail to do that many, many times. All right, so I won't comment on their intelligence. Just tell you it happens. So what does that mean? Well, when I was young, before some of you were even born, it wasn't uncommon for politicians to say, well, the Republicans and the Democrats agree on the goal. We just don't agree on how to get there. And today, when it comes to health care, if that's the situation, that's bad for Republicans. Because if the Republican and the Democrat agree on the goal, and the Democrat has a simple solution, and the Republican has a complicated solution, guess who wins? Right? And I was with a group of people the other day, and this institute came in with a suggestion on how Republicans should run on health care. They had about 7 or 8 catchphrases that they thought would be really good with the voters. And they spent a lot of time talking about this. And the catchphrases included things like we want low-cost care, we want high-quality care, and we want to preserve the doctor-patient relationship. And I went down the list and I said, look, I hate to disappoint you all, but there's not a single thing on your list that a Democrat would agree with. So if you rush out there with that, the Democrat agrees to all of that, then where are we left? We're left with a simple solution versus a complicated solution. And by simple solution, it's almost always just spend money. And I'm going to get to that in just a moment. 5th rule that we want to follow is ignore the special interests. Democrats are very good at this. The way we got Obamacare, and there's a whole book written on this by Stephen Brill, sitting around a table, we had big insurance, big hospitals, big pharma, business roundtable, all these guys, each wanted something, each didn't want some other things, and they hashed it out, and that's why you got Obamacare. If those guys walked away, there would not have been Obamacare. So you wonder, why does Obamacare have some of the strange features it has? Because pharma had to buy in, insurance companies had to buy in, they had buy-in for all these people. But the ink is barely dry on the Democrats' achievement, and they're out there on the campaign trail criticizing greedy insurance companies, greedy drug companies, attacking the very people who gave them the bill that they wanted. Republicans, on the other hand, are excessively loyal when no loyalty is deserved. Republicans went a decade. And during that decade, there were many times when they controlled the House or the Senate or both. And they never held a single hearing on the problems of Obamacare. And what I mean by the problems are the ones I talked about a moment ago. You know, the woman whose deductible is so high she's got a brain tumor, she can't afford to go get an MRI scan. Somebody with cancer who can't afford to go get the chemotherapy. Because the deductible is so high. I mean, there could have been a parade of witnesses going before congressional committees telling their own stories. So over and over again, I would ask my friends in Congress, why aren't you holding hearings? Why aren't you bringing in these witnesses? And here's what I think the terrible answer is. The insurance industry told us not to. Okay. Well, why was that? Well, because once the witness is through testifying, what the Democrats are going to say, this is because of greedy insurance companies. This isn't our fault. This is their fault. Now, the way managed competition works is there are really three main things that you compete on, potentially. You have benefits, you have premium, and you have out-of-pocket exposure. Now, to have managed competition, or to have competition at all, the government can only set one of those. You can't set two, there's nothing to compete upon. So you set one, and then you allow the insurance companies to compete on the other two. So Democrats were really smart. The one they wanted to take credit for were the benefits. Because then they could say, I got you your free mammogram, I got you your free contraceptives, I got you this, I got you that. And take credit for all of that. And then, when the premiums are out of sight, when the out-of-pocket costs are out of sight, when the networks are too narrow, that's that greedy insurance company. That's their fault. When in fact, all the insurance companies are doing is responding to incentives that were created for them. Okay, now, what do we do about this? Well, with my friend Mary Fishpaw at the Heritage Foundation, we began to think about, well, how can the 5 principles I just laid out for you, how can it work for people who believe in private health insurance, competition, individual choice? How can it work for us? And so we came up with about 8 to 10 ideas, and we're calling it right now, for lack of a better word, the Health Contract with America. Some of you are too young to remember, but way back in 1994, Newt Gingrich led the Republicans to take back the House for the first time in 40 years with a contract with America. In fact, I helped do the tax components of that. So I sent this off to Newt Gingrich, and he liked the idea, and we're sort of moving along. But we start with, okay, we're going to end the outrageously high out-of-pocket costs that people are facing. We're going to end these very narrow networks, which deny people access to the care they need. And what I'm now doing is I'm talking to you in terms of benefits. I'm not getting, if I were running for office, I would not get bogged down on how we're going to do it, although I can discuss it with you guys. And that's the way our contract went. Now, some of the things in our contract, like telehealth, were made possible by Donald Trump. And so let me talk about him. Let's see how we're doing on time. Let me talk about Trump for a moment. Trump presided over the greatest deregulation of health care imaginable. This could never have happened under George Bush. Probably wouldn't have happened under any other Republican president. Unfortunately, Donald Trump doesn't even realize what happened. And I'm serious about that. I tried my best to get Donald Trump to campaign on the health reforms that happened under his presidency. And by trying my best, I mean I went to his own personal doctor. I went to the White House and briefed, all the policy people. I called Brooke Robbins. I did everything I could do, and it didn't work. So Donald Trump was out there, and let me just give you a few examples. Before we even knew what COVID was, the Trump administration deregulated the production of vaccines. So I'm not talking about warp speed. I'm talking about deregulating how you create a vaccine. At the University of Chicago, they estimate that this deregulation sped up by at least 6 months the production of the COVID vaccines and saved 180,000 lives. When's the last time you heard Donald Trump say that his administration saved 180,000 lives? I'll tell you what else it did. Telehealth some of you may know this, but when COVID hit, there was a law in Congress which prohibited Medicare doctors from talking to their patients by phone, by email, by Skype. I mean, it's a law that says you can't do this. It wasn't just an executive order or anything like that. Now, you don't just snap your fingers and say we're going to have telehealth, because there's 7,500 things Medicare pays doctors to do. And somebody had to go through the list and say, okay, this is good for telehealth and this isn't. And are we going to pay the same for audio, or audio plus visual, or virtual, or as against in-person? All those decisions had to be made. And the Trump administration got into this 3 years prior, or for over those 3 years. They were planning on how to get telehealth into the healthcare system and allowing the Medicare Advantage plans some flexibility to do some of this anyway. If Hillary Clinton had been president, we would probably eventually have been able to talk to our doctors by phone and email and Skype. But it would have probably taken another year because her administration would not have done all the background work to get ready. They didn't know COVID was coming, but they believed in freeing the market and letting people do what made sense. Donald Trump made it possible for every employer in the country right now to give the employee pre-tax dollars so that he can have health insurance, which he owns, and can take with him from job to job and in and out of the labor market. How many of you knew that? Well, let me tell you why I think you didn't know that. Because it's nowhere in the mainstream media, and it's not even in the healthcare media. And what's worse, I was there at the Rose Garden ceremony where the executive order was signed. Now, before Trump, under the Obama administration, if an employer gave the employee dollars, pre-tax dollars to buy his own insurance, or if the employer just paid for the individually owned insurance. Think about this. Blue Cross sells group insurance and individual insurance. The employer buys the group. And suppose the employer decided to buy the individual insurance for each of his employees. That employer could be fined under Obama $100 per employee per day, $36,500 per employee per year. And although this may have been going on here and there, in some states it used to be don't ask, don't tell, that brought everything to a close. So Trump comes along and completely reverses that. So I go to the Rose Garden ceremony thinking I'm going to hear Donald Trump tell us how wonderful this is, and he reads some stuff, and I left and think, Donald Trump doesn't understand what we just did. And the whole Republican Party didn't seem to understand what just happened. Sometimes I think, what would happen if all this were reversed? What would happen if Obamacare were a Republican plan? How long do you think it would take the Democrats to hold hearings on how bad it was working? A week? In 2 hours, he says. All right. Same with personal portable insurance. Something good for workers like that. I don't think they would not be talking about it. All right. So, and there are other things that Trump did. Complete deregulation of healthcare. And had Trump talked about these things, I just wanted to try. I told his own personal position. I just wanted to hold the phone up and talk to seniors and say, I got this for you. I did this. This is my administration. But for me, you wouldn't be doing this. He would have been president today, I think. That's how important healthcare is, and that's how important I think the missed opportunity was. So now let's talk about the Democrats in Congress. I want to talk about the healthcare part of the $3.5 trillion monstrosity. And it won't surprise you to learn that 2/3 of the money is going to the elderly, who already are way over subsidized, I'm sorry to say. When we think about what we do for the elderly versus kids and versus other people in need. All over the country, there are thousands of developmentally disabled kids on waiting lists for Medicaid. And these guys are not doing anything for these kids. They want to spend dollars on the seniors. And it's always, in every case, throwing bad money after good. Good money after bad.
Kids don't want them.
Yeah, all right. But they don't believe in reforming bad institutions. They believe in spending money. So what's wrong with home health care today? Well, almost 1/3 of the seniors who qualify on leaving the hospital for home health care never get it. I'm not sure why. we're not studying this, but they don't get the benefit they're supposed to be getting. And then we have a huge problem of fraud, and we have a huge problem of theft. And it's very difficult for seniors to be whistleblowers and complain, because you have this Medicare bureaucracy. If the senior complains, they can just miss their next appointment or give them a less qualified caregiver. Seniors don't feel like they can take on Medicare when they're being mistreated, and the money goes to the bureaucracy. What's in the bill? Well, what's in the bill is a big fat payment for home health care that in 6 states is more than it would cost in a nursing home. In almost every state, more than it would cost an assisted living facility. And the bill doesn't cover assisted living, even though that's where a lot of seniors are these days. And overlooks what I think is one of the most successful healthcare programs ever invented. It's called cash and counseling. Any of you ever heard of that? Just real quickly, cash and counseling. This came from a liberal foundation, Robert Johnson Foundation. They put up the initial funding to do the pilot program. What it does is it gives money to the homebound Medicaid disabled. They have a budget, and they can hire and fire people. And so if their service provider isn't up to speed and giving them what they need, they can fire that person and hire another person. This program, in the early days, they did polling and found satisfaction rates in this program was in the 90%. And I can almost guarantee you can go anywhere in the world and you will not find that kind of satisfaction with any healthcare program anywhere. But empowering patients and giving them control of money has a big payoff in terms of patient satisfaction. Well, that's not in the $3.5 trillion bill. And by the way, in some states, these days, this program has expanded. In some states, a spouse can be the caregiver. So what you're really doing is giving the family money to manage on their own. Ear, dental. Well, the Liberal Commonwealth Foundation says, well, we ought to have at least a $1,500 benefit for every senior on Medicare. $1,500, I'm going to guess, you all would know this better than I'm going to guess that's what you would save if you joined a Medicare Advantage program and didn't have to buy Medigap. Am I right about that? Okay, so you say, because most Medicare Advantage plans, you pay with your Part B premium and not much more. And these plans also offer, in most cases, dental and eye and hearing benefits. So by joining the Medicare Advantage program, not only does the senior get pretty much the kind of benefits Congress is talking about, but $1,500 in cash as well to pay their share of the patient co-payment. Then, what do we have? Medicaid expansion. Texas is a non-expansion state, so what they want to do to us and all other states like us is create a Medicaid-like program. And what's wrong with Medicaid? Do I really need to tell you? 1 out of $10 is lost to fraud. 1 out of $4 goes to somebody who isn't qualified to be in the program at all. A third of doctors aren't taking any new Medicaid patients. And those that do, well, if they take you, they see you last. You know, the lowest paying patient is the last one the doctor wants to see. And maybe worse than all that is the fact that it's an unstable insurance plan. So all of you who are in the top half of the income ladder, you may not know very much about what life is like at the bottom half of the income ladder, but people's income goes up and down like that. So the average person, an average adult on Medicaid is there for about 9.5 months. Average child on CHIP or Medicaid is there for 10 months. And that's because once your income goes above 38% of poverty, you can't be in there anymore. If it goes below that, you can't be in Obamacare, you have to be in Medicaid. So you do not have a long-lasting relationship with the insurer. Now, if you're healthy, you may not care, but if you are a chronic patient with lots of problems, you need a continuing relationship with your physicians. And these days, that means a continuing relationship with the health insurer. Then on Obamacare, instead of reforming it, instead of dealing with the problems I talked about earlier, they want to spend more money. in the, on the unsubsidized part of the market. So they had a 2-year subsidy that passed the other day. Now they want to make that permanent. This is the higher income folks, people who make more than 400% of poverty. And why? This part of the market has been in a death spiral. And again, they don't want to reform the thing, they just want to spend money. Reform means the deductibles come down, the networks get wider. Reform, in my view, means making Obamacare look like Medicare Advantage. In Medicare Advantage, people are not running away from the sick. In Obamacare, every insurance company has incentive to attract the healthy and avoid the sick. You know, I was meeting with the folks at Anthem the other day, and I said something to them that kind of surprised them, although they should have known this. I said, outside of Medicare Advantage, there is no place in our healthcare system where anyone wants a sick person. There is no employer that wants to hire a sick employee or employee with sick family members. There's no insurance company that wants them. No plan anywhere. But this isn't unique to the United States. It's also true in Canada. It's true in Britain. Do you think a hospital with a global budget wants a really sick, expensive patient in its system? No. So all over the world, there's incentive to avoid people with really difficult health problems. But Medicare Advantage is an exception. And I'm on the Medicare Advantage plan. I get a little booklet. And once a year, this booklet says, well, here are the diabetes plans, and here are the plans that deal with heart, and so forth. They can specialize. And you can't join the diabetes plan if you don't have diabetes. So they can ask health questions. They can ask to see your medical records. None of that can happen in Obamacare. No plan can specialize. No plan can ask health questions. No plan can say, you know, we want to see your medical records. If you don't fit, you can't join. Totally not allowed. So what I mean by reform of Obamacare is making it work more like Medicare Advantage, where plans specialize and get good and compete to meet the needs of people who are sick. And right now that's not happening, not allowed to happen. So what else have we not covered? We've got Medicaid, we've got Obamacare. Drugs. I don't know if this is going to happen, but the fifth big expenditure item that the Democrats are talking about is putting a limit on out-of-pocket costs for drugs. Now, how are we doing on time? I'll wrap up here in a second. The only reason to ever have Medicare was because seniors had medical bills they couldn't afford. Medical bills that might bankrupt them, might cause them to lose their house, their pension, and so forth. There's no other reason to have Medicare. And yet from the very first day it was formed, if you look at the structure of benefits, Medicare was paying for small dollar items that even people trying to live on Social Security could probably afford on their own, while leaving seniors exposed for thousands and thousands of dollars of out-of-pocket costs. This has gone on since the very beginning. Now there's been some improvement through time, but right now the worst of what I'm now talking about occurs in prescription drugs. So I think it's $475 is the deductible. On the next dollar, Medicare pays 75 cents, a senior pays 25. The dollar after that, again, 75, 25. This is money that almost any senior could afford on his own, okay? And their Medicare is paying for it. But once you get up to $6,000, $7,000, you reach the catastrophic point at which the patient is responsible for $6,000 or $7,000 of out-of-pocket costs on part of the patient. Once you get above that, for the really expensive drugs, the patient's hit for 5% of their costs. And so we have patients out there spending thousands and thousands of dollars out of pocket for prescription drugs, even though they have Part D coverage. So here again is a very flawed program. And if you really cared about seniors, you'd want to change this program. Rational insurance means you allow individuals to self-insure for the small stuff. The insurance company handles the big stuff. That's not the way Medicare has ever been. It's not the way Medicare is now on drugs. So the way I would sum up the Congressional Democrats' approach to all these areas is they do not believe in reform at all. They only believe in spending money, and there seems to be no limit to how much they're going to spend. And once they've spent it all, you're still gonna have ridiculously high deductibles in Obamacare, ridiculously high exposure on the drug side, and a home health care program that's not working for the patient. It's working for the bureaucracy. Okay, I didn't do bad, did I? Getting through all of that. Okay, let's open it up and see what you all want to talk about.
Well, I'm hearing the advertisement about that they're going to limit drugs. So do you think that's going to come to fruition? I don't take drugs, but if I did, I wouldn't want them limited, the kind of drugs. And also, how would you think about rationing care that they're talking about coming down? And this is all for seniors.
All right, so what you may be thinking about.
Can you repeat the question, Dr. Goodman?
What?
Can you repeat the question? We can't hear.
She said she'd read about the idea of limiting drugs people have access to. So here's why I think you heard about that. Democrats keep talking about Medicare negotiating with drug companies. The Congressional Budget Office looked at this several years ago. It says you're not going to save any money if Medicare negotiates with the drug companies as long as it takes every drug. Remember Donald Trump's famous statement, you've got to be willing to walk away from the table? Well, if you're not willing to walk away from the table, you're not going to accomplish much. The VA system, by the way, does walk away from the table. And that's why its drug costs are low. There are a lot of drugs that the VA just doesn't pay for. But if Medicare, and by law now, I think it has to cover virtually all drugs, if it's going to cover everything, then the negotiations aren't going to materialize. So that may be what you're hearing. What was the second?
Oh,
thing?
rationing care.
Oh, rationing
What
care.
if we're coming down to all these expenses, which we can't afford as taxpayers, doesn't it stand to reason we're going to see more rationing care in the general population? Not just old, but young too.
Well, we're not going to ration care the way the Canadians do it or the British do it. We're already rationing care by price, in my opinion, in the Medicare drug program. We're rationing care by price for the disabled children under Medicaid that are now on a waiting list and can't get care. And some of them are dying, by the way. By estimate, quite a large number of kids die on the waiting list for getting care. So we ration care in that way, but not nearly as bad as Canadians, not nearly as bad as the British. We don't have a global budget. Yes, sir.
Dr. Goodman, you mentioned reform, specifically the ACA, Obamacare, to end high out-of-pocket costs and narrow networks. What are some of the things that you discuss with Newt to get to these goals? What are the proposals?
Well, the most important thing we can do is change the risk adjustment. So let me say just a few more words about that. If you're an insurance company, you don't have to think, and everybody's paying the same premium. You do not have to think very long to realize you're going to make a profit on healthy people and you can lose money on sick people. How long do you have to think about that? And that's where we are. And that's true of employers, it's true of health plans, it's true of everybody out there except for Medicare Advantage. I noticed a long time ago that employer plans are designed to attract the healthy and avoid the sick. And why is that? Well, here are these employer plans that pay for all this primary care. This is before Obamacare, paying for primary care. But if you went to the hospital, you had tens of thousands of dollars that you could pay out of your own pocket. How does that make sense? It makes sense if the employee is thinking he's going to go to the hospital, right? And if the healthy person doesn't even think about the hospital. Here's what you have to know about this market. Healthy people tend to buy on price. And sick people look at networks and they look at deductibles. So the reason why the deductibles are so high and the networks are so narrow is because they don't want the sick and they want the healthy. So by getting the deductible high, by getting the network narrow, you can bring down the premium. And that's what attracts healthy people. So it's a market with these are what I call perverse incentives. This is not the way a health care system should be organized. In Medicare Advantage, the plan gets a premium that gets a payment from Medicare. that reasonably reflects the cost the plan's going to have for care. And that's why plans specialize and advertises. If you have diabetes, come to us, or if you have heart disease, come to us. And, I don't know if you all know this, but if a doctor discovers a change in health condition, let's say a doctor discovers you have cancer, then that doctor can send that information to Medicare and the plan gets an increased payment. This is the only place in the whole healthcare system where a change in health status means that the providers get more money. Everywhere else, change in health status means you get less money. So risk adjustment is the key to reforming Obamacare. And I keep praising Medicare Advantage. I wrote a whole paper on 10 things we could do to make Medicare Advantage even better, so I don't want you to think it's perfect, but it's a lot more perfect than Obamacare. Yes, ma'am.
I have lots of questions. The first question.
Pick the best one.
Well, you're talking about that in this system that, I guess from a standpoint of the insurance company or employer, they don't want the sick person. But the providers want the sick people with insurance. I mean, let's be honest, they don't get paid unless they treat people. So why is it that we are not looking at keeping people healthy and managing these chronic conditions? You know, I mean, you hear all this talk about the COVID thing, and the people who are dying from COVID have comorbidities, and those comorbidities are, you know, immunization, autoimmune, heart, diabetes, overweight. Those are the things that are causing people to, I mean, see what I'm saying? To die, well, to die, but also to deserve more care.
So I'm going to tell you my solution to keeping people healthy and the typical corporate solution. So the typical corporate solution is you shouldn't smoke, you shouldn't overeat, and all of that. And so we have a culture of healthiness. And so, but the problem with all that is they're saving money for Medicare, you're not saving money for the corporation. If you quit smoking today, you're not going to prevent cancer tomorrow. You're going to prevent cancer when you get closer to Medicare. So you're saving money for taxpayers, not your employer. So why do employers do this? Because culture of healthiness is a signal to all potential employees. If you're healthy, we want you. If you're not healthy, you may not fit in very well in our corporation. So it's, I think that's all I'll say about bad motives on the part of employers. Now, what my solution is, the health savings account solution, I would like people to manage more of their own healthcare dollars. I would like the insurer or the employer to be able to give money to the diabetic patient if they're willing to manage their diabetes. And let's say here's $2,000, $3,000, whatever it's going to be. And if you are compliant with your drugs, you stay away from the emergency room, and you save money, it's going to be money you keep. If you're not compliant, you go to the emergency room a lot, that's going to come out of your pocket. So you reap the benefits of your good decisions, you pay the cost of your bad decisions. So I think motivating the patient is a really good idea. I'll come back to you. She hasn't asked yet. Okay.
Kind of two-part question. What are your thoughts on lowering the age to get going to Medicare, and two, increasing someone's annual salary in order to get a subsidy from the employer's perspective? Is it good, bad, and different? So it's two different parts.
All right, let me answer the first, and I'm not so clear about the second, but we'll come back to that. What's wrong with lowering the age of Medicare? Well, if you pay a fair price, I mean the real cost, we don't have a subsidy. Medicare is a lot worse than any plan these people are already in. I mean, think about Medicare. You have to pay to have the kind of coverage you get from an employer. You have to pay 3 premiums for 3 plans. Right? You don't do that with the employer. You have to have a special, drug plan and this and that. So it's inferior health insurance plan. People are getting better from their employer. They may even get better in Obamacare. Now, I didn't understand the second question.
I heard them talk about increasing someone's salary, well, not their income, in order to get a subsidy when you go through Obamacare, like through the ACA, that you're trying to get a subsidy from the government to help pay for your So instead of,
You're talking decrease.
I thought they were increasing their salary. So instead of like instead of increasing their salary, right? Well, yeah.
Well, there used to be income
They're too
limits.
low, right?
So you had to be 38% of poverty in order to go into Obamacare. If you blow that, you're in Medicaid. And then on the top end, it topped out at 400% of poverty, and there was no subsidy. Oh, that's crazy. But now you get subsidy above 400% of poverty. In fact, under the new system that they want to make permanent, a family making $500,000 a year can get a subsidy from Obamacare. But I've not heard of an employer changing someone's salary so that they could benefit from Obamacare. Yes, sir.
Yes, Dr. Goodman, can you comment maybe on, it seems as we went to unlimited on our claims rather than the $2 or $5 million limits we used to have before, we've seen the catastrophic claims come up to that point. Surely that's got an effect on price too. Should there be limits?
I'm glad you asked. Because when we were talking about reforming Obamacare, I said risk adjustment is the most important thing. The other thing that has to happen is we have to limit the catastrophic exposure of the insurer. Way out on the tail, it can get really dicey. I mean, it's possible for an insurer to pay $1 million a month for a patient. So every insurer is going to be thinking about that, and that's ridiculous. So what almost everybody who's thought about this very much says is we need to reinsure those high costs. That's something the safety net can do. And not only should the plans not have to insure for the really high dollar, but individuals shouldn't either. So back before there was Obamacare, did any of you know what kind of insurance people at McDonald's used to have, or Burger King, or fast food restaurants? Typically, an employer would offer them Blue Cross, but they have to pay a substantial premium, or almost for free, what I call limited benefit insurance. Limited benefit insurance means first $25,000 we pay for, after that we don't. Or it could be $50,000. Guess what everybody chose? Well, unless their kid had a really expensive problem, they all chose a limited benefit insurance. And I think we need to think about that and understand it. If you're a young, healthy family, and you're living paycheck to paycheck, you don't have any assets, you have moderate income, you are not thinking about $1 million premature baby that might come your way. And even if it did come your way, you don't have $1 million. So giving you $1 million insurance plan doesn't change your life at all. The hospital's not going to kick the baby out on the street, right? We're going to take care of that baby. So I believe we ought to let families have the kind of insurance that meets their medical needs and their financial needs. And so I really believe in limited benefit insurance. And let the safety net handle the big cost of occasion will come along, but that's why you need a safety net. And let families choose insurance that meets their medical needs and their financial needs. And for some moderate income people, that may be a relatively low catastrophic limit. Yes, sir.
And by safety net, you mean the government providing claims payment?
By safety net, I mean the government, although you can think of the safety net more loosely as shifting money from private paying patients to the patients who don't pay. But mainly I'm thinking in terms of what federal dollars do. Some of those dollars ought to go into a safety net, and some ought to go to private insurance. And we shouldn't expect the private insurers to cover every claim.
So it's going to come from increasing taxes onto it?
With money that's already there. You know, there's a study by Milliman, and there's another study that I looked at. By the way, on the $3.5 trillion, if you want to go to my website, you can find a lot of what we've been talking about, plus a lot more. And one of the things that's there is this reference to two studies that say, look, we can take the same money and put some aside for reinsurance so that the insurers can reinsure their high-cost patients and stay in the business of insurance for everybody else. And And that brings down premiums for everybody, and is a more rational way of organizing the market. Yes, sir.
What is the website?
GoodmanInstitute.org. GoodmanInstitute.org. I think my picture is there. But it's a younger version of myself. Yes.
Have the Republicans ever messaged on healthcare? Well,
No. No, they never have. And by the way, it's not just health care. The Republicans have a tendency to want to over-intellectualize things. And, I don't want to say they're more honest, but what works in politics is talking about benefits, right? And that may not be honest all the time, but that's what works, talking about benefits. But it's not just health care, it's just about every area you can think of.
I know, kind of behind the camera, so I'm using it.
Sorry.
All right, I'll go.
Yeah, so I have a question. So obviously in Texas, we used to have a high-risk pool. Many states did. ACA removed those from all states. So what is the position, because our Medicaid and our straight state of Texas is awful. So is there a thought process for reinstituting state, not state exchange, but state risk pools to help our uninsured?
Okay. When a moment ago I talked about reinsurance, I'm talking about the idea of a risk pool.
Okay.
You know, some people will say, oh, a risk pool, you're segregating us over here, you're going to mistreat us, we're not treated the same way. I'm talking about what's sometimes called an invisible reinsurance pool, which means the patient never even knows what's going on. But if he's high cost, those costs are being shifted over here to a state fund. And one of the worst things Obamacare did was it allowed every state, like Texas, to end its risk pool and dump a lot of sick people into the Obamacare market. In fact, the reason why Obamacare has done so poorly is because what I call dumping, whether intentional or not, the states dumped their risk pool, folks, into the exchange, competing against healthy people. The group plans dump sick people into this market. I can remember talking to people who had a job only because it offered health insurance. And they were afraid if they retired early and went to the individual market, they wouldn't be covered. Well, now they can retire early and go to the individual market. Good for them, but not so good for the market. And then we have really atrocious things like the city of Detroit. So we promised all this post-retirement health care, we can't afford it. We're going to send those folks to the Obamacare exchange. I think 7,000 or 8,000 people. And now taxpayers are paying for what previously the city was supposed to pay for. So dump it. So in my view, in a well-run insurance market, no plan would ever be able to dump sick people on another plan. No plan would ever be able to undertreat, for example, a cancer treatment, cancer patients, have that patient go to some other plan. If he did, the plan that drove the patient away would have to pay the new plan that increased costs. And I think if we were doing things like that, the market would be totally different. We'd have what I think of as a market for sick people, where it's in the self-interest of health plans to attract people with problems, to solve their problems. And if you can solve their problems in a low-cost, high-quality way, you make a profit and the patient's better off. That the health market should work like a normal market. And every problem that you all are aware of is because we have suppressed normal market forces. And the party in power doesn't believe in normal market forces, so that doubles the problem. Yes, ma'am.
Okay, another question that I have. You talked about the cost of prescriptions and about how if you cover everything, then obviously you have no negotiating power. I'm fairly old and I've been in this business a long time, and I remember when PPOs came out and managed care came out, and the networks were very narrow, and then people complained because they couldn't go to Presbyterians, and then, Blue Cross said they had Presbyterian, but you complained if you couldn't go Vegas, and then they did. So, do you think that having the wider networks in
here's what I think employers should do. The mistake employers make is they don't want to share the benefits of healthcare savings with the workers. So if you go, if you need heart surgery, you fly down to Cayman Islands, you can do it for Medicare price or less. Let's say you save $15,000, okay, and top-rated doctors. I mean, all board certified. They're Indians from India, and the employer wants to say, look, if you'll get on a plane, fly down, and your spouse can go with you and stay down there while you're doing it. So the employers, some employers, want to say, look, employee, if you'll go down there, I'll waive the deductible. You save $1,000. Yeah, he saves $14,000. So to me, the employer is not thinking the right way. There ought to be more generous savings, and if there were more generous savings, employee attitudes would be different. So let's say, I remember Blue Cross once telling me, and it may still be true, that in their normal plan, there's not a single hospital in the whole DFW area that they don't cover. They told me this several years ago. And I said, well, why is that? You mean no matter how bad, no matter how costly, no matter what the quality is, you're going to cover that hospital? I said, yes. Well, why is that? Well, if the CEO's wife, if we left out a hospital, her doctor wouldn't go there, and that causes problems. So it's easier for us to cover everybody and just pass on the cost to the employer. So what I would think about doing if I were an employer is I would say, I think we can identify maybe 4 or 5 really good hospitals, and they are very high quality, and they don't cost as much as the other hospitals. And if you employees will agree to limit our hospitalization to these hospitals, I will say $500,000. We'll say $5,000 per employee, and I'll split it with you, or give you most of it. Well, that would totally change everybody's attitude, because then the employee is gaining from the narrow network. And that's the kind of narrow network which improves quality as opposed to Centene. That narrow network is a race to the bottom. Are we going beyond where we need to be?
Just one question. Is there any chance Obamacare gets repealed at any point?
No.
No.
And I never thought it would be. And so what I've encouraged Republicans in Congress is, look, Democrats put just in the exchange alone, let's call it $50 billion a year. They put $50 billion on the table. Why not use it for rational health reform instead of wasting it, which is kind of what we're doing right now. Yes, ma'am.
What are your thoughts on reference-based pricing rather than having a network at all?
Well, I think, and you all know what that is, reference-based pricing. Some of you do. My favorite example is in California. CalPERS has all the California employees, all the retirees, all the families, thousands of people, huge. And Anthem was their insurer. And for hip and knee replacements, they did a study of all the hospitals in California, and the cost of a knee replacement ranged from $15,000 to $100,000. So it's all over the map. And so they identified 40 or so California hospitals that consistently came in under $30,000 and high quality. And so they said to the employees, you can go to any hospital you want to, but all we're going to pay is $30,000. And so Anthem said, we want to do this. The state agreed to do it. And in the first year, 1/3 of the people still went outside the network. But after 2 years, the average out-of-network, outside of these 40 hospitals, the average out-of-network fee for a knee replacement went down below $30,000. And when you stop to think about that, think about how much time, energy, and whatever insurance companies spend negotiating with hospitals. The back and forth, on and on and on. Out in California, Anthem did not pick up a phone, did not mail a letter, said nothing to the hospitals. They just sent employees into the market knowing $30,000 was all the money they had to spend. And the supply side reacted quickly. That could be happening everywhere, in my opinion. That's called reference pricing. I don't know who thought of that terrible name for it, But it's setting a limit on what you're gonna pay and then letting the employee pay more if they want.
I mean, we've got plans to do that now with, you know, around here, you know, there's TPAs that are negotiating fees at freestanding facilities.
Yeah.
You know, surgical centers where their average price for knee replacement's $20,000 versus Baylor here at $50. And if you go over here, you don't pay a deductible, you don't pay co-insurance, it's paid 100%. You go over here, you pay your $5,000 deductible, $800 out of pocket. I mean, that's.
I don't know if you're all gonna hear him, but he says we're doing something like that here in Dallas.
Very common in the TPA.
Okay. Anything else? Well, you've been a good audience.